Hello everyone and welcome back to my channel. In today's video we're going to talk about water movement in Starling Forces. Why is water movement important to understand, especially in anesthesia? Because we have some medicine that are lipophilic, so they like more water, and you want to be able to know which compartment of the body system get most of that medicine when you administer versus other medicine that are lipophilic that like more fat. And also different alteration in water movement in the system can be clinically significant in diseases and other mechanism process. So today we're going to see how is water divided into our different system. So our total body water is not the same for any compartment in the system. So actually 80 to 85% of our total body water is going to be in the brain and the kidneys. So yes, the brain and the kidney gets more of our total body water. Next to it, 70 to 75% of our total body water is going to be inside the lungs and the heart. Next to that, 65 to 70% of our body water is going to be in the liver, the muscles, and the skin. Now, these are the organs that takes most of our body water, and also we have 50% inside the plasma or the blood. And if we remember from our other video, most of these systems form the central compartment system where drugs are getting metabolized and eliminated. Now next to that, we have 20 to 25% of our total body water inside the bones. Yes, the bones, they get a lot of total body water too. And 8 to 10% for the teeth. I actually didn't know this part when I was studying. Yes, we have up to 10% of our total body water inside our teeth. Now, not only the water differ in different compartments of our body system, it's also differ according to the age. Like when we are newborn, when we have a newborn are made of up to 90% of the total body water. And this amount have a huge decrease when we get to the childhood. In the childhood, we have about 65% of total body water. And now when we get to the adult, we have about 60%. And as we age, this amount keep declining. So why, as we age, the total body water is declining? It's because as we age, the kidneys become less functional, so they have the ability to retain more water decrease. They can't really concentrate the urine, and all the adults too, their thirst mechanism is altered. They don't really feel when they are thirsty, and also they have the muscle that shrinks, and we saw that muscle comprise 65 to 70% of the total body water, and they have more fat. And it's been proven that the more we get fat, the less our total body content we have, and men have more total body water content than female. Now we're gonna talk about the case of an adult with 60% of body water, because most of the books are ranging special topic about around this adult age. So if we have an adult, like we said, the adult has about 60% of total body water. This is approximately equivalent to 42 liters. So how is 42 liter repartition into our body? So 42 liter, 40% is going to be the intracellular fluid inside the cell. And this is going to be approximately 28 liter. Yes, inside our cells we have more fluid. Could you think about it? I didn't. So 40% of the 60% of the total body water is going to be found in the cell at 28 liters, and the rest, the 20%, is going to be outside the cell, which is called extracellular fluid. Now, the extracellular fluid is divided into two compartments. We have the interstitium and the plasma. Now, later in this video, we're going to talk more about the interstitium, which is really important. But this interstitium takes 16%, which is going to give approximately 11 liter, and the plasma takes 40% only, which is going to be 3 liter. And if the plasma is only 3 liter, the interstitium 11 liter, and the intracellular fluid 28 liter. So most of our water content is actually inside the fluid, inside the cell. Sorry. So now that we know how water is repartition across the different compartments of our body, and also across the lifespan, and how it's actually divided inside our body, we're going to talk about the Starling Forces, the dynamic of water between the cells, the interstitium, and how this can affect us clinically. Now, Starling Forces are the forces that maneuver around the water, if I can say so. They are the forces that pull the water in, that pushes the water out. And to understand it better, I'm going to try to draw a picture of the compartment in our body. So this is going to be a capillary. Now, as we know, or as we might know, or as we might not know, capillary are made of the venous end and the arterial end. So this is going to be our capillary. And here, I'm trying to make this color coded so it can be easy to understand. And here we have the interstitium. Remember, we say the interstitium has about 11 liter of our total body water. So we have the interstitium, and here inside the interstitium we have our cells, and here we're gonna have the lymphatics. The lymphatics who are gonna drain the fluid from the interstitium to go back into the thoracic duct and dump into the superior vena cava. Now, let's look at the Starling Forces. The arterial, when the cardiac output comes down here, and after the left ventricle pumps out the blood and it goes into the different compartment, when it gets to the capillary, it comes on the arterial end. So that pressure from the cardiac output is going to be creating a pressure right here. So on the capillary side and interstitium side, we have different pressure. But here, the hydrostatic pressure, which is called PI, in the capillary PC, is the force of the water that the water exerts on the capillary. So this force is going to promote filtration from the capillary. So it's going to promote the movement of the fluid out of the capillary. So it's going to push the water out of the capillary. So this pressure is going to push the water here out of the capillary. Now coming down on the arterial, from the arterial side into the venous side, we have a pressure here who is going to be called the oncotic pressure inside the capillary. So the oncotic pressure inside the capillary is the pressure that the big molecules like the protein, they exert inside the capillary to pull the water in. So this force is going to go in, it's going to promote the movement of fluid inside the capillary. Now, for the purpose of the video, I'm not going to go through the numbers, but we just have to know that on the arterial end, we have this hydrostatic pressure, but the oncotic pressure is minimal on the arterial end. That's why I did not even mention it here. And on the venous end, the oncotic pressure is way greater than the hydrostatic pressure here. So that's why I only mentioned the oncotic pressure on the venous side. So to recap, on the arterial end, our force of filtration is going to be high. The hydrostatic pressure is going to be high, and hydrostatic pressure push the water from the capillary inside the interstitium. And here, our oncotic pressure, the pressure from the protein, is going to try to pull the water inside the vascular space. Now, on the interstitium end, if we come right here, we have the same forces, but they act differently. So our hydrostatic pressure inside the interstitium, the hydrostatic pressure, what it does, it pushes the water out. So it's going to push the water out from the interstitium. So because it's the interstitium, is PI. So our hydrostatic pressure in the interstitium push the water out, and our oncotic pressure is going to pull the water in. And our oncotic pressure here is going to pull the water inside the interstitium. And these are called the Starling forces. Normally, this is what should be happening from the capillary to the interstitium. So on the capillary end, we have the hydrostatic pressure in the capillary trying to push the water out, and the oncotic pressure here trying to pull the water in. And from the interstitium side, we have the capillary in the interstitium pressure that try to push the water out, and inside the interstitium space, we also have the oncotic pressure that try to pull the water inside the interstitium. Now, according to the Starling forces, our net filtration pressure from the capillary. So, net filtration pressure from the capillary are going to be the forces that promote filtration minus the forces that oppose filtration. So if we look at the forces that promote filtration from the capillary, so moving the fluid out of the capillary, is going to be our hydrostatic pressure inside the capillary, pushes the fluid out of the capillary, and our interstitium oncotic pressure that help the fluid inside the capillary. Now, and the opposing forces, the forces that try to keep the fluid inside the vascular space, is going to be the oncotic pressure in the vascular space plus the interstitium hydrostatic pressure, who's trying to pull back the pressure into the vascular space. So, and this gives us a net filtration from the capillary. Now, let's talk about the lymphatic. In normal circumstances, the fluids that is in the interstitium is going to be drained inside the lymphatic, and it's going to be drained into the thoracic duct, which is going to be dumped into the superior vena cava. Now, this is what happened in the normal state of the body. Now, if we have alteration in one of these forces, this can result in different disease mechanism. For the sake of this video, we're just going to talk about edema, how edema results from the alteration of this mechanism. Now, there are 4 principal mechanisms of edema. If we have an increase in our hydrostatic pressure, and if we have a decrease in our oncotic pressure, decrease in our capillary oncotic pressure, and if we have an obstruction to the lymphatics, and if we have an increased permeability here of the capillary membrane. So how this works? Remember, edema is defined as the accumulation of fluid into the interstitial space. So whatever there is an alteration that is going to bring more fluid here, is going to be the origin of the edema. Now, if we have an increase in this pressure, the fluids are going to be pushed out, hydrostatic pressure, filtration, push out into the interstitium, and we're going to have more water here. Now, different conditions can lead to the increase of the hydrostatic pressure when we have retention of sodium and water. That's the case of like hypertension, where we have a lot of water. If we have a fluid overload in the body system that is extremely increasing our cardiac output, like left ventricular failure or right heart failure, it's going to increase our hydrostatic pressure here, and this hydrostatic pressure is going to push the fluid more into the interstitial space. Another case is going to be a blockage here. So if our veins don't work at the end of the vein, the pressure is getting backed up here, this increases the capillary hydrostatic pressure. So these are the 3 cases where we can have an increase in hydrostatic pressure. I'm going to put here in case of hypertension, fluid overload, it could be heart failure or kidneys, or venous obstruction. Venous obstruction, which could be thrombophlebitis or venous insufficiency. These are the things that are going to increase our hydrostatic pressure, promoting more fluid into the interstitium and giving us edema. Now, second point, a decrease in capillary oncotic pressure. So if we have a decrease in capillary oncotic pressure, there is not enough force to pull the water into the vascular space, so the water stay into the interstitial space. And as we talked earlier, the oncotic pressure is the pressure exerted by the proteins. Now, so if we don't have enough protein, we have a decrease in our oncotic pressure. So things like malnutrition can give us a deficit in our protein intake and reduce our capillary oncotic pressure, and water stays in the interstitium. Things like liver failure. Liver is the manufacturer of our protein. So if the liver is not working properly, we're going to have a decrease in the plasma protein, and obviously in decrease in our oncotic pressure. And severe burns. So in burns, we have a huge leak of those plasma protein, decreasing our capillary oncotic pressure. And also during nephrotic syndrome, we are losing a lot of this protein, decreasing our oncotic capillary pressure. The next thing is going to be obstruction to the lymphatic. So if this fluid in the interstitium is not getting drained by the lymphatics because of an obstruction right here, the fluid is backed up into the interstitium. Things like blockage to the drain of multiple lymphatic sites can give us a lymphedema. So they call it lymphedema. And essentially, the lymphedema is different from the edema caused by all these other mechanisms, because this edema is going to be hard. It's not going to be pitting as the edema into the interstitium. And our last mechanism of edema is going to be increased permeability into the capillary membrane. So if here I have bigger pores that allow more fluid to go into the interstitial space, I have edema forming. So what could increase this capillary permeability is going to be things like burn, sepsis, infection. Is going to give us a huge increase in our capillary permeability. Sepsis, burns, inflammation. So this is what I had for us today, and I hope this help understand the different water movement and the Starling forces and how edema can result from alteration in any of these forces. If you like this video, please share, subscribe, and like, and also leave a comment below if you have any suggestion or you have any question or just want to talk about anything. Thank you so much, and see you on my next video.